I am looking for any rashes, any lesions, any wounds, skin breakdown, if they have wounds, the stage of the wounds, the appearance, any drainage, any itching, and that will be assessed, like I said, throughout the whole body. So as I'm assessing the scalp, I will be looking at hair distribution. I will be looking for any abnormalities, any lumps, any bumps, any softness. The next thing that I will assess is the face. And I also want to note that for each body system, other than the abdomen, which I'll cover when I get there, the nurse, me, will inspect, palpate, percuss, and then auscultate. So back to the face, I will first assess the eyes. So I will assess the pupils, the iris, the conjunctiva. I'm going to note any tearing, any redness, any swelling, any discharge. I am also going to assess perla, so the pupil should be equal, round, and reactive to light. I will use my pen light to assess accommodation to make sure that the pupils are constricting in response to light. I will also assess the 6 cardinal signs with the pen light, holding it 12 to 14 inches away from the patient's face and moving it 6 ways. And while doing this, I am looking for any involuntary eye spasticity during the movement. The next thing that I will assess would be the patient's ears. So I will assess one ear and then the other side. And again, for the rest of the body, when you assess one thing on one side, you also are going to assess it on the opposite side. So in the ears, I'm going to take my pen light, I'm going to look inside, make sure there's no abnormal discharge or signs of some sort of infection, that there's no blood inside the ears. I'm looking for redness, swelling, symmetry. I can look behind the ear lobe for any bed sores from oxygen tubing from a nasal cannula. And then I'm going to ask the patient if they're able to move their head to the other side, and I'm going to assess the other ear. During this process, I can also assess cervical mobility as they move their neck back and forth. The next thing I will assess is the nose. Again, I'm looking for symmetry, swelling, bumps, lumps. I'll take my pen light and look up the nostrils for any blood. I also would note any nasal flaring at this time or prior if noticed. That could be a symbol of trouble breathing. The next thing that I would assess on the face is the lips and the mouth. So for the lips, I'm looking to see if they're dry, make sure they're pink and they're not blue, which could be a sign of cyanosis. I am going to look inside the mouth for any lesions and ask the patient to stick out their tongue. At this point, the tongue is a symbol of their hydration status. So is it pink? Is it moist? I'll ask the patient to smile for facial symmetry. If there is not facial symmetry in the smile, it could be a sign of a stroke. I'm also going to assess the teeth, the gums. Again, make sure there's no blood, no swelling. Swollen gums could be a symbol of gum disease. And at this point in time, I can also assess some of their hygiene, see when they brush their teeth. And I would also ask dietary questions. So I would ask the patient on their food and fluid intake, when they last ate, what they last ate, how many times a day do they normally eat, what does a normal meal look like for them, how much water do they drink water, what other drinks do they drink, such as juice, coffee, soda, things like that. The next thing I would do is make sure that the trachea is midline, and I would assess each carotid pulse one at a time, noting not to assess both carotid pulses at the same time. That is very important. After I finished my facial assessment and made sure that the carotid pulses were checked and the trachea is midline, I would move on to the chest area. So again, I would be inspecting skin, I would palpate, I would look for any symbols of the patient being in any pain, any wincing, any complaints, any moaning, any groaning. and I would continue to listen to the heart sounds. So I would use my stethoscope. I would palpate and identify the second intercostal space on the right sternal border, and that is where I would listen to the aortic valve. The pulmonic valve is directly across second intercostal space, left sternal border, and I would listen to that. I would go down one space to the third intercostal space and listen to Erb's point. The fourth intercostal space, still left sternal border, is the tricuspid valve. And then the last heart sound that I would listen to would be at the fifth intercostal space, left midclavicular. And whether male or female, I would use the back of my hand to lift up the breast tissue, place the stethoscope there to listen. This is the mitral valve, also known as the apex of the heart. The apical pulse is listened to at this part of the body, and it is also the point of maximum impulse. If the rate is regular and the rhythm seems normal, if the rate is within normal limits and the rhythm seems normal, I would listen for 30 seconds. If it seemed abnormal, I would listen for a full minute. If the patient is a female, I could, or male, regardless, inspect the breasts, ask them if they do regularly check their breasts, and then I would move on to the lung sounds. So there are 3 types of lung sounds that can be listened to in an anterior position. The first sounds are the bronchioles. They are located in the tracheal area right near the sternum. And again, what I do on the right side, I'm going to do on the left side. I would use my stethoscope, ask the patient to take a breath and listen. At this point, the inspiratory effort the inspiration should sound less than the expiration. Then I would move to my bronchiovesicular sounds, which are right at the sternal border, and you can listen to them at the first and second intercostal spaces. At this point, inspiration is equal to expiration. And then the third sound I can listen to are the vesiculars, which are at the peripheral lung field. So they're more on the sides. And at this point, the inspiration is greater than the expiration. So once that is finished, I would cover them back up. I'm also going to note that whatever body part you are assessing, you uncover while you're assessing, and then prior to moving on to the next part of the body, just make sure that it is covered back up. The next part of the body that I am going to assess is the abdomen. This is different than the rest of the body because I will inspect first, but I will auscultate prior to palpating. I'm going to do this because I don't want to interrupt with any bowel sounds or create any false bowel sounds. So again, I'm going to inspect the skin. I'm going to look for any bruising. Is there distension? Any lesions, any rashes, things of that nature, and then I am going to auscultate. I would start at the right lower quadrant and then move on to the right upper quadrant, to the left upper quadrant, and finally the left lower quadrant. In each quadrant, I am waiting to hear bowel sounds. If for some reason I hear no sounds, I would listen for up to 5 minutes in each quadrant to confirm that there are now no bowel sounds. And then from there, I can palpate each quadrant and ask the patient if they are feeling any pain as I do so. The next thing I would do in this area is I would ask them if they are having any nausea, any stomach pain, any issues eating, when their last bowel movement was, are they having any constipation, diarrhea, any issues going to the bathroom, what does their stool look like, what is the consistency, things like that. After doing that, I will uncover their genitalia. The only thing that a nurse does at this point is inspect. We do not touch. I will be inspecting for swelling, redness, rashes, lesions. I will ask the patient when they last urinated, are they having issues urinating, any painful or burning when they urinate, things of that nature. After that, I will palpate the femoral pulses, one on each side, to compare. The next thing that I would do if this were a female is ask them when their last menstrual period was. After that, I will move on to the legs. I will inspect range of motion, again, skin, flexibility, going along with range of motion, pain. I will also palpate the popliteal, the posterior tibial, and the dorsalis pedis pulses of each leg and foot. I will ask the patient to bend their knees on each side, one at a time, and compare the differences. I will also assess strength, ask the patient to lift their leg up, hold it up against pressure. Same with their feet. Can they push on the gas against pressure? Can they flex their feet? I will assess their nails. I will look at capillary refill, which should be less than 3 seconds. I will also note if there's any clubbing to the toes, which would be an indication of long-term oxygen or long-term poor oxygenation. I will also assess color of the peripheral feet, and if the patient is able to stand, I can ask them to stand. I can assess their gait, their posture, their balance, their coordination. And then from here, I would personally move on to the arms. So again, same as the legs, I would assess the pulses. So I would assess the radial and the brachial pulses, range of motion, strength. I would ask the patient to touch their nose, touch their head. I ask them to squeeze my 2 fingers. Can they push and pull on using their hands to assess strength? And same as the legs and feet, I would assess capillary refill to the fingers, should be less than 3 seconds. If there's any clubbing, things of that nature. The last thing that I would assess would be the back. So I would ask the patient to roll over. I would assess the skin. I would again assess the breath sounds posterior. So you cannot do the bronchioles posteriorly, but you can do the bronchiovesiculars, and also I did vesiculars anteriorly, but you can also do them posteriorly in this position. I would assess for any sores, any skin breakdown, any lesions, if there are any hemorrhoids and things of that nature. Is the patient's skin moist? Is the patient dirty in terms of feces or urine? At that point, I would clean them up, assess for any wounds in the scapula, the sacrum, the base of the skull, the back of the ears. And that is it. I would then make sure the patient is in a comfortable position, ask them if they had any questions, talk to them about whatever they needed to discuss, make sure they had their call bell. I would make sure the bed's in lowest position, the side rails are up, they had everything they needed, and then prior to leaving the room, I would wash my hands and take all of my equipment with me. And that's it.